on long-term care and helping facilities with regulatory requirements and also defending them in medical malpractice lawsuits. So what today we're going to talk about is the antipsychotic use in nursing homes. I know that right now everyone is really focused on COVID, as they should be, and I'm certain that nursing homes are very appreciative of all that you guys are doing to help them address and fight the spread of the virus. And so antipsychotics aren't really at the top of everyone's list, but something that we should focus on, and I'll say why that is here shortly. So make sure I can go forward with my screen. So first we're going to talk a little bit about background. But Megan just put up a poll. I thought it would be interesting, one, because I can't see you all, and I don't know, I mean, I can see the list of participants, but it'd be nice for me to know what your area is. If you have a board certification or specialty, if it's in internal medicine, geriatrics, psychiatry, or other, I'd be interested in that, just given the topic. So if you would, click what you are. I'll choose other since I'm an attorney. And Megan, if you could, I don't know if you can share with me the results. I'm not sure how that works, but again.
I think once the polls ended, we should all be able to see it.
Okay, great.
So I'll give everybody a couple more seconds.
Great. So while we're waiting for the results, what I'll cover today is the background, a little bit of background on the focus that has been shining on the use of antipsychotics in nursing homes, some of the regulatory requirements, and that'll be the focus of our discussion, and then some specific issues and ways in which I think that you guys can help nursing homes going forward in trying to reduce the use of antipsychotics and psychotropic medications. All right, so she's sharing the poll. Looks like 20% are internal medicine, 23% geriatrics, and 10% psychiatry, and then other is 47%. So the most of you are in another area of practice. So maybe I didn't choose the best backgrounds, but so that's good to know. So the first slide I have put up is an article. You know, when you Google use of antipsychotic or psychotropic medications, something pops up, and it's this article on Human Rights Watch. They want docile, and basically the article is it almost reads like a plaintiff's attorney, honestly. Why they are giving medications to people with dementia, and it's basically they're basically saying we're doing it to keep them in their beds and keep them docile and not, we're using it for our convenience is essentially the message that they were giving. And I just found that interesting and wanted to point that out, is that that's how some people view the use of these drugs in our nursing homes. All right, so a little bit of background. As you probably know, in 2017, the regulations were updated, and now the unnecessary medications, the tags that relate to that in a survey are F757 and F758. And so when we talk about the regulations, those will be our focus, and those will, the guidance to surveyors are certainly going to be our focus today. I did ask the Department of Public Health, I was talking with Mia and Lisa before today, and asked them what the message they would like to share with you guys. And their plea was, you know, we really need to focus on getting these reduced. And so as we go through this, you'll see that that is certainly the focus and intent of the regulations, and the focus and intent that has spurred all of this on. So in 2019, the OIG, the Office of Inspector General, actually added unnecessary medications as a focus to its work plan in 2020. And it noted that in 2019, it was the sixth most frequently cited deficiency between calendar years 2013 and 2017. And so that when it becomes part of their work plan, it certainly is something that should be on our radar as well. So the National Partnership to Improve Dementia Care in Nursing Homes is a partnership with federal and state agencies, nursing homes and providers, and advocacy groups. And their focus is on how to improve comprehensive dementia care. And they certainly keep track of and monitor the statistics with regard to the use of antipsychotics in nursing homes. Their website, the information on CMS website about this partnership, it says its goal is to promote a multi-dimensional approach that includes public reporting, state-based coalitions, research, training, and revised surveyor guidance. CMS announced that the national partnership met its goal of reducing the national prevalence of antipsychotic medication use in long-stay nursing home residents by 30% by the end of 2016. And its new goal is to reduce the use by 15%. And actually, this is kind of timely in that the brand new numbers for 2020 came out on January 22nd. And Beth Green with Alabama's QIO was nice enough to share that information with me yesterday. So I've tried to incorporate it here. So the PowerPoint that you may have been provided may be updated here, and I'm happy to provide the updated one to Megan to share with you all. The measures and goals that are used by the National Partnership, the measure is the percentage of long-stay nursing home residents, so not short-term, not the rehab folks, who are receiving antipsychotic medication, excluding those residents diagnosed with schizophrenia, Huntington disease, or Tourette syndrome. CMS acknowledged that the circumstances exist where clinical indications for the use of antipsychotic medications are present and does not expect the national prevalence of antipsychotic use to decrease to 0. So that's good news. So they do at least acknowledge that there is a purpose and reason to use antipsychotics for folks in nursing homes and in folks with dementia, but they would like to see that those numbers decrease. So here's the list of the prevalence of antipsychotic use for long-stay residents by state. And you will see, I know it's kind of small, but if you could zero in on the first line, which is Alabama, our lovely number is 51. So we are last, which is not a good place to be. We usually can rely on Mississippi or Louisiana to help us out there, but unfortunately they didn't do it this time. So we are at the bottom of the list. This are all 50 states in the District of Columbia. And so not a good number, not a good place for us to be when it comes to the prevalence of use of antipsychotics. Again, here's sort of the chart reported by quarter from 2011 to 2020, and it is a steady decrease, which is what they want to see, and it gradually goes down. So let's see if I can undo my annotation and move forward in the slides. So I put up the numbers that I found before she shared with me 2020's numbers yesterday, and you can see in 2015 we were actually 45th in the use of antipsychotic use, and then we have gradually gone down the list. In 2018 again we were 51st, and then in 2020 we remained 51st. And if you wanted to find this information, I have provided the link to that data report for you in case you want to go check it out yourself. I also had at one point a list by facility on antipsychotic use. I didn't include it in the slides today, but certainly if you are interested in finding, your particular facilities that you visit and serve as medical director for, you can find that information and go see how your facility ranks and fares. As I mentioned, the OIG pointed out in 2019 that the unnecessary medication use for antipsychotics was the 6th most cited. This shows that as of between 2018 and April of 2019, it is now the 8th most cited deficiency state, across the country. I didn't have the most recent data for where 758 falls in Alabama, but considering we are 51st, I don't think it probably bodes well for us. So with that in mind, right now we're not having regular surveys, annual surveys. So this information is only through the April 2019. And right now the focus is on infection control. And as you can see, it also ranks very high on the list. So the regulations, F757 and F758 are the deficiencies that are cited when a facility has been deemed to be using medications unnecessarily. F57, 757 is for general medications, any type of medication that they find is unnecessary, excessive dose, sorry for the typo, excessive duration, without adequate monitoring, without adequate indications for use, in the presence of adverse consequences, and any combination of the above. So those are the basis to cite an F757 or 758. 758 is the one that focuses on psychotropic and antipsychotic use. They define a psychotropic drug as any drug that affects the brain activities associated with mental processes and behavior. These include antipsychotics, antidepressants, anti-anxiety, and hypnotics. Again, the use of a psychotropic drug must be based on the comprehensive assessment of a resident. Although this is really, it focuses on what the facility's job is, you'll see that you all play a very large role, and the attending physician will play a very large role in preventing the facility from getting a deficiency in this area, along with the pharmacies and those coming in and doing the medication regimen reviews. So facility is required to ensure that residents who have not used a psychotropic drug are given unless the necessary to treat a specific condition. And you'll see that is the key here, is that if you are prescribing and administering a psychotropic drug, there must be a specific condition documented and diagnosed and recorded in the clinical record. And that's very important, and that's where you guys come in. The resident, they must ensure that the resident who uses a psychotropic drug receives a gradual dose reduction, and that's referred to throughout the regulation as a GDR, and that behavioral interventions are used in an effort to discontinue the drug unless they are contraindicated. There is a focus on the use of psychotropic drugs for PRN on a PRN basis, and that they must be limited to 14 days unless the attending physician or prescribing practitioner can document a rationale in the medical record for continuing that PRN medication for more than 14 days. It cannot be renewed unless the attending physician or prescribing physician or prescribing practitioner evaluates the resident. And we'll talk about that more in a few minutes. So the intent behind the regulation, as stated by the surveyor guidance, is to maintain the highest practical mental, physical, and psychosocial well-being of the resident, which is one of the keys of the surveyor regulations is throughout. Again, we mentioned gradual dose reductions. That's going to be a focus. And I was looking back at some previous notes from these meetings, and in 2016, we were talking about this, and I had a note where Dr. Gary, who was with the Department of Public Health, was talking about psychotropics and antipsychotics and how medical directors and attending physicians could help nursing homes. And his point was, and I think this still holds true, is that any tapering is a good thing, and that if you can show that you are tapering, then that will be to the facility's benefit. It doesn't have to be a significant tapering of the dose, but it does need to be some showing that you're making a reduction at some point. Again, PRN orders are only used when medication is necessary and the use is limited. I already talked about that, the F758 and 757, 758 being a focus of psychotropics. So it's interesting, who's coming in and evaluating and making the call as to whether there's a deficiency related to psychotropic use. It's surveyors, right? And they aren't physicians and they aren't pharmacists. They may be nurses, they may not. So their background and their training isn't going to be the same as yours. And it's not, so it's interesting to me that they can make that decision as to whether or not a medication is necessary or unnecessary. And so the regulation and the surveyor guidance says, how you surveyor are you able to determine if it's inappropriate to use a medication? And they say that surveyors are expected to investigate the basis for decisions and interventions affecting residents. And so how do they do that? They're going to look at the medical record. And if there's not documentation there that supports the medication, then they are likely going to find that it's an unnecessary medication. It does say that the regulations and the guidance are not intended to supplant the judgment of a physician or prescribing practitioner. And that is, certainly worth repeating, that they cannot supplant their judgment for yours or a prescribing physician or a pharmacist who makes a recommendation. So, we ought to keep that in mind as we go forward, is that they are not the same in terms of their training and expertise and experience. And so questioning a physician and questioning, the use of the medication does, require us to have to take some really close look, and if they cite that as a deficiency. Proper medication selection and prescribing may help stabilize or improve a resident's outcome, quality of life, and functional capacity. This is from the surveyor guidance under 757 and 758, which are combined. The guidance to surveyors is combined for those two deficiencies. Use of a medication without adequate indications in an excessive dose for an excessive duration or without adequate monitoring may increase the risk of a broad range of adverse consequences. And they list those as being potential depression, confusion, immobility, falls, fractures, and death. I'm certain that you guys have been doing this for a long time. I guess I'm going on my 17th year. And again, my focus is on nursing homes. And so, I know I'm not a physician, although my husband likes to think that I play one sometimes, but those things that they've listed, depression, confusion, immobility, falls, hip fractures, and death, certainly there are other causes other than medications that are not, again, related to the use of medication. So, to list those, it can be a little bit misleading, because if a surveyor is looking for those keys or those issues to arise, there's certainly other causes and other reasons why a resident might have those things or those interactions. So issue spotting, this is what, again, there are basically 4 keys that they're supposed to look for, and that's indications for use, the dose, the duration, and monitoring. And that's listed under medication management. And those are the keys for reviewing F758 and 757. As part of all medication management, it is important for the, my little key here, for the IDT to implement non-pharmacological approaches. The IDT being the interdisciplinary team, of which the medical director would be a part of. And it's designed to meet the individual needs of each resident. When the surveyor, where the regulations changed in 2017, they became very person-centered, and they're supposed to be individualized approaches. And so everything that you see throughout the guidance suggests that you can't have sort of a one-size-fits-all for your residents. And so you need to make sure that when you are evaluating or when you are implementing medications or interventions, that they are individualized and focused on that particular person's needs and problems. One of the things that they, again, focused on is the implementation of non-pharmacological approaches. Certainly, I think that care plans oftentimes include different types of approaches for residents when they have issues, behavior issues. Things that are mentioned as non-pharmacological approaches include altering the environment, relaxation techniques, activities, music therapy, and spiritual support. I know that there's been a lot of articles out there and a lot of information, at least that I've seen, about music therapy and its benefits for residents with dementia. And so I know that that's been something that could be used in place of or in addition to medication to approach. I think we have a chat, so I'm getting a little distracted, but I wanted to make sure if there are any questions that I address those, because I do prefer these to be interactive, but because it's virtual, it's very hard to do that. So the surveyors, again, the guidance says that the attending physician plays a key leadership role in medication management, which you would expect since you are the ones prescribing and with that authority. And so, but they also expect that the resident, their families, be involved in those choices and in those decisions to take or prescribe certain medications to control behaviors. Medication management includes consideration of the following: the need for the medication, which would be what you're documenting, the reason why they would need it, the dose. They talk about duplicate therapy if they're on some other type of medication that would address the same problem. Duration, how long they're on the medication. Again, PRN is a focus of theirs in the regulations. Are the facility or is the facility monitoring for efficacy and adverse consequences? And you as the attending, when you come in and do your evaluations of the residents regularly, are you making sure that the medications that you've prescribed are having the intended consequence and actually benefiting the resident? You want to make sure you're preventing and identifying and responding to adverse consequences that might be from the medications. Additional requirements for psychotropic medications includes that they should be only used when necessary to treat a specific diagnosis and documented condition. And so what I would want you all to walk away with from this discussion today is document. And, you know, my litigation side of things, that's something I always focus on, but from a surveyor and a regulatory side of things, this is important too, because the facility is going to need to be able to back up the use of that medication. And if you didn't put it in the medical record, why you prescribed it, why it's needed, then they're going to have a hard time defending that use. Again, you must implement GDR, the gradual dose reduction, and include non-pharmacological interventions, unless those are contraindicated. You have to limit PRN psychotropic, which are not antipsychotics, to 14 days unless a longer time frame is deemed appropriate. If they are antipsychotics, you can only use them for 14 days, and you cannot renew that order without first evaluating the resident. They recognize in the regulation that there are isolated situations where pharmacological intervention may be required first, which it sounds a little odd. I mean, and I'll get to some scenarios here later, but you know, they're saying that the use of medication to control behaviors or assist with distress is not the first intervention. It should be something else. It should be something non-pharmacological before you try or attempt some type of drug. And even in those instances where you are first trying a medication, then you should also include non-pharmacological interventions as well. So again, there were 4 things: the indications for use, the dose, the duration, and the monitoring. So to talk about the indications for use, again, the medical record must show documentation of adequate indications for the medication's use and diagnosed condition for which the medication is prescribed. And so back to the documentation, you want to make sure that you as the physician are writing in the record why you have chosen that drug and why you are using it for what condition. The evaluation process is important to selecting initial medications in non-pharmacological approaches and when deciding to modify or discontinue a current medication. So the facility should be evaluating and monitoring you as well as the physician. Evaluation of the resident includes these factors. The causes for the symptoms what other causes for the symptoms have been ruled out. So if there's some other reason why the person is experiencing the symptoms, then that has to be evaluated and ruled out. Whether the physical, mental, behavioral, or psychosocial signs are related or related causes are persistent or clinically significant enough to warrant initiation or continuation of the medication therapy. whether non-pharmacological approaches are implemented, whether a particular medication is clinically indicated to manage the symptoms or conditions, and whether the intended or actual benefit is understood by the resident and is sufficient to justify potential risk of adverse consequences. Additional information to be considered is the mental, physical, psychosocial, and functional status of the resident's goals and preferences, any allergies, history of prior or current medications, that sort of goes towards the duplicate therapy issue, recognition of need for end-of-life or palliative care. That's certainly something that has become to the forefront of our industry is how to plan for and evaluate end-of-life care and whether or not the use of those types of medications are necessary if palliative care is, or end-of-life care is what has been chosen. What's the basis for declining care or medication and treatment? So if the resident has, or the resident's representative has chosen not to take the medication, what's the basis for that? And again, documentation of the indications of distress, delirium, or other changes in functional status. When should the evaluation occur? On admission or readmission, a significant change in condition, a new persistent or recurrent clinically significant symptom or problem, a worsening of an existing problem or condition, an unexplained decline in function or cognition, a new medication order or renewal of orders, and an irregularity in the medication regimen review. And again, that's performed by the pharmacy or the pharmacy consultant. One of the things that was noted was that if a pharmacist is recommending a reduction of a certain degree and the physician doesn't necessarily agree with it, that is not a basis to cite the facility for a deficiency at this tag. And I think that's even in the surveyor guidance, is if there's a disagreement between what the medication regimen review says and what the pharmacy or what the physician decides to do with regard to that medication, the discrepancy there is not solely a basis to cite the facility. The PRN orders must be prescribed to treat a diagnosed condition, and they must be within the requirements of the 14 days. Dose. So this is the second factor. Why was it prescribed? That's part of the evaluation of, is the dosage correct? Why it's prescribed, the route of administration, and whether or not there are other drugs that have been prescribed for the same or similar condition that might have a duplicative effect. I'm going to go back real quick to this. So one of the things they note is that duplication is high during transitions of care. So if a resident's coming from a hospital to the nursing home and the hospital has put them on certain medications, and when they come into the facility, the attending physician is evaluating what drugs to prescribe, they're saying that it's oftentimes can result in duplicative therapy because whatever the hospital prescribed and whatever the physician describes on admission may either overlap or be duplicative. So something to be looking out for. Duration. What is the clinical rationale for the continued use? PRN medications obviously become a focus when you're talking about antipsychotics and psychotropic drugs. And then common considerations. Is it a time-limited condition like nausea, a cough, infection? Is the medication administered beyond the stop date would be excessive duration? And that's more of a facility issue, obviously. If a facility, if you've prescribed an antibiotic or something for 7 days and they've gone beyond that period, then that would be considered excessive duration. PRN being requested or administered regularly, should it be scheduled rather than PRN? So if you go in as the attending and you're reviewing a resident's chart, and you see that their PRN medication is being given regularly as opposed to just as needed, then is it necessary to change that to a scheduled dosage rather than PRN? The monitoring. This is something that's probably more on the shoulders of the facility, but certainly something that the attending physician should be doing when they're evaluating and coming in on their regular visits, and verifying that the diagnosis or cause or of signs or symptoms relates to, verify that the diagnosis supports the drug that's being prescribed. Does the care plan support, have interventions, both the pharmacological and the non-pharmacological interventions? are you optimizing the therapeutic benefit and establishing parameters for evaluating ongoing need, and then tracking the progress and or decline of the resident and the symptoms for which it's been prescribed. Okay, I've got a comment here, so I'll chime in. It looks like Dr. Uford says, it's my training that a patient who has undergone 2 attempts to taper off an antidepressant over a 2-year period should stay on the antidepressant unless they want to stop it. Many patients have had tapering many years prior to admitting to the SNF, yet we are required to taper these patients off the antidepressant. If I document this history, can I not put the patient through the required GDR? That's a very good question. And I guess the point is that if tapering hasn't worked, is that a basis to not continue to evaluate the tapering? I would say from a regulatory standpoint, if you are documenting that on a regular basis, that you either know the history and that the history shows that it doesn't work and they have to do that, then you would want to continue to document that you are evaluating that on an ongoing basis. And it looks like Megan would like to answer the question as well.
Oh, no, I was just clicking answering that you were answering it live.
Oh, okay, I'm sorry. I don't know. This is my first time doing this sort of Q&A from my standpoint. I usually get the questions asked to me at the end, but I like the interaction, so thank you. Yes, I just would say that the documentation is key to that. If you are saying that they've tried it, it's been attempted, and it didn't work, then certainly if you are evaluating that on an ongoing basis, then you should be able to support that decision. But I would be very cognizant of the fact that you need to be documenting that even on the quarterly basis, I believe is what they want you to do on the GDR, but I'll get to that in just a second. So residents must not receive medications not clinically indicated, obviously, to treat a specific condition. And that goes back to the documentation that must be in the medical record. It must contain a diagnosed condition for which the medication is prescribed. So even if the diagnosis list for the resident clearly shows that they need this medication, when you're prescribing the medication, you should indicate that is what the prescription is for. It must be to treat the resident's specific diagnosed and documented condition and its benefits to the resident as demonstrated by the monitoring and documenting of the response the resident has to that medication. Again, that's going to be somewhat on the facility and the nursing staff to make sure that they're documenting that they are monitoring and the effectiveness of the medication, but you should as well in your progress notes. I may have gone past my, okay. So psychotropic drug use, again, it says that, acute or emergency, it must be consistent with PRN and GDR. Is it to address an enduring condition? New admissions. So, here's one of the things that comes up a lot, at least in my world, is that, they were admitted on a psychotropic drug. And it presents challenges in identifying the use of the drug or the indication for the drug. So if they're admitted with it and you're going to continue it, what specific condition are you going to document that it is necessary to treat? Attending physician must reevaluate the use upon admission or soon after admission. So that is one of the requirements too, is that if they're admitted on one, then you as the attending must evaluate the use of that drug once they come into your setting. Monitoring for antipsychotics and psychotropic drugs. After initiating or increasing, behavioral symptoms must be reevaluated at least quarterly. So that's back to the idea that you must be evaluating quarterly to determine if there's a potential for reducing or discontinuing. If adding or switching, there must be documentation. You must document the rationale for that. You must be monitoring for adverse potential adverse consequences, and some of the ones listed for the surveyors to be on the lookout for are the flushing, blurred vision, dry mouth, altered mental status, difficulty urinating, falls, excessive sedation, constipation. They have cardiovascular issues, metabolic, or neurological. And again, you know, what the problem I see with this that I mentioned before is that, you know, surveyors are not physicians, and the things that they are supposed to be looking out for can have multiple causes. And so what's to say that the medication is the particular cause of that? Certainly, falls are very common in nursing homes, and difficulty urinating. I mean, they could have another medical condition that's causing that. So, you know, could be problematic if that's what they've been told to focus on when those have multiple causes. If medication is possible cause, the facility and the prescriber must determine whether the medication should be continued and document the rationale for the decision. Again, there's the D word again. You must thoroughly document the rationale for prescribing. The IDT, the interdisciplinary team, must identify and address any medical, physical, or psychosocial causes and or social environmental triggers prior to prescribing an antipsychotic. You should be using the lowest possible dosage for the shortest period of time, not TI, sorry, and it's subject to GDR, the gradual dose reduction. So lowest dose, shortest time, and you should look to reduce it over the period of the resident's time. Diagnoses alone does not necessarily warrant use. Now, doesn't that sound odd, considering they've told you all throughout these guidance, all throughout the regulations, that you should document the diagnosis that supports the medication? Well, that alone apparently doesn't necessarily warrant the use of the drug. So a little bit of a double-edged sword there. But the drug may be indicated if behavioral symptoms present as a danger to the resident or others, expressions or indications of distress cause significant distress to the resident. If it's not contraindicated, have multiple non-pharmacological approaches been attempted but did not work, and has GDR was attempted but the clinical symptoms return. And back to the question that was asked, you know, the reduction in antidepressant over the course of 2 years, and they continuously have to go back on it. Does that support the use of the medication over time? There's a question here that says, if a patient is for short-term rehab, 3 weeks or less, is it reasonable to just keep them on their psychotropic, especially if on it prior to the hospital stay? The comments or the regulations say that you should be evaluating that on admission or soon thereafter. My opinion would be, and this is where I really wish that there was a way for us to interact, but my opinion would be is that you should at least evaluate and document the reason for continuing that. And if it's the fact that they're on short-term rehab and to discontinue the medication could potentially be contraindicated because they were on it prior to and they're likely to go home with, then you know, I think if you're justifying and documenting the justification for that shortly after admission, that would be sufficient. You know, a lot of the discussion, a lot of the data is focused on the long-term stay resident, although again, the regulation specifically says that you should be evaluating on admission or shortly thereafter. And I would think that 3 weeks is enough time to get in there and evaluate the use of that. And if you continue it, just document the reason why you're continuing it. Okay. Next slide. Gradual dose reduction. So again, the purpose is tapering the medication to find the optimal dose. Well, to me, that would indicate that you wouldn't necessarily reduce it to zero, that you might, that resident might actually need the medication. And I think that there is obviously some recognition in these regulations that a psychotropic drug can be necessary, and many residents need that medication. And whether, you know, so you must also determine whether the continued use is benefiting the resident. And so if it's having an adverse consequence, that's that they're becoming, you know, overly sedated, they're staying in their bed, those types of things need to be evaluated. But the idea is that you're getting it to the optimal dose. And benefiting the resident. So when should GDR occur? Clinical condition has improved or stabilized, so your resident is improving, and unfortunately, are they improving because of the drug? And so when you start reducing it, if the clinical symptoms come back, then that reduction may not have been warranted or necessary. Are the underlying causes of the original target symptoms resolved? Is that a reason to reduce the drug or remove it entirely or discontinue it? Have non-pharmacological approaches been effective in reducing the symptoms? Have redirecting, music therapy, or other types of other types of interventions been effective in reducing the symptoms as opposed to the drug alone? Who should do the GDR? Who and when? The pharmacist does a monthly medication regimen review. The attending physician should do it when they're reviewing a plan of care, orders, or evaluating the resident's response, and it should be done as part of the MDS quarterly review. If the resident's condition has not responded or has declined, you would want to evaluate both the medication and the dose according to the regulations. Within 1 year of admitting, so this is where, again, this is about long-term care residents, but it says, or long-term stay residents, but within 1 year of a resident being admitted on a psychotropic medication, or after the prescribing practitioner has initiated a psychotropic medication, the facility must attempt a GDR 2 separate quarters with at least 1 month in between. So that is the time frame within which the GDR should be conducted. After the first year, the GDR must be attempted annually unless it's contraindicated. And when it says that, I would certainly recommend and advise that if the physician thinks it's contraindicated, that they document specifically that the GDR is clinically contraindicated. Contraindications include that the symptoms return or worsen after the most recent GDR, and the physician documents the rationale why the dose reduction would likely impair the resident's function or distress behavior. So if the resident, you attempt the GDR, the symptoms return, the symptoms are worse, and the physician says, okay, well, that GDR didn't work, we need to go back to the previous dosage amount, then that needs to be documented specifically in the record. This is from Julia Booth, and she says, we have an increased percentage of inpatient long-term psychiatric residents, previous resident of Bryce, for example. Their antipsychotics are not for dementia. Is there certain wording you recommend for the charting? Obviously, their appropriate diagnoses are already present, but the repeated asks to stop meds that have allowed them to be discharged from Bryce. Specific wording. So if they're on an antipsychotic, not for dementia, is there certain wording recommended for charting? I don't off the top of my head have specific wording that I can think of. I think, and I would defer certainly to clinicians on this, but I would suggest that specifically saying that they are a long-term psychiatric resident in need of the medication. I think that your words related to why you continue the medication should be sufficient. Again, this is one of those things where I really would love to have others chime in. So if there's a way, and I don't know if there is, Megan, for anyone, I guess you could put it in chat maybe, is that a possibility?
Yes, and if anybody wants to chime in, they can always put it into the chat box, and we can have a conversation there, and then you and I can read things out as we go along.
Okay, and yeah, and I actually don't know how to look at the chat while I'm doing my share the screen. So I'm sorry I'm not more helpful on that, but if I can think of some additional types of words that would be helpful, I will certainly share those with you. I can get your information from Megan, but what I would say is that is probably what we're seeing a lot of, what the description you just said, which is facilities are now required to care for psychiatric patients. We are pretty much the only place for, there's just not a lot of mental health out there in Alabama, probably many states, but Alabama, certainly we have a lot of issues with the fact that we don't have a good mental health system to support residents who really need that type of care as opposed to nursing home care. And one of the scenarios that I talk about at the end, which I think I'm pretty much getting close to my time, is that what you'll see is we send these patients with behaviors to a we send them out to a geri psych unit, and at the geri psych unit they pretty much fill them with drugs, right, to get their behaviors under control. And then they get their behaviors under control with these medications and want to send them back to us because they're stable. Well, they come back to us and we cannot continue what they had done at the psychiatric facility because we are under these regulations. And so we start tapering off, and what happens? They get worse. Their behaviors come back. And so it's almost a never-ending cycle for us, in that we're stuck under these requirements where the other hospitals, psychiatric facilities, they can all do this other type of medication to address the symptoms that they need the medication for. And then yet they come back to us and we are trying to address those same problems. We just are under a different regime, which is unfortunate. So again, you must continue to try the GDR, PRN medications, very specific with regard to how long you can have the PRN for a psychotropic, not antipsychotic, can be 14 days and can extend beyond if the physician believes it's appropriate, so long as they document the rationale. An antipsychotic PRN, the physician must first evaluate the resident. And they go on to say that evaluation must be direct. It cannot be that the nursing home calls you and says, Miss Smith is her PRN we've gone 14 days. She's still having these issues. Can you renew the order? You cannot just say, yes, I'm gonna, I'll renew the order. You must actually physically examine the resident. And at a minimum, you must document why it's needed, what the benefit is, and have the resident's expressions or indications of distress, just went forward too fast, improved as a result of the PRN medication. Now we're at the issues. Some of the things, again, I mentioned already that I see is resident coming from a psychiatric facility whose behaviors were controlled at the psychiatric facility because they were all on these medications, and we're required to change that. It looks like Dr. Harrison has shared some language regarding if 2 or more attempts have resulted in deterioration in the condition for a previous diagnosis, then the GDR is contraindicated. He says, recommend restating this on an annual basis. So I think this goes to both maybe the first question and the second question regarding what you can do about a resident who comes in and they've tried gradual dose reduction and it didn't work, and as well as the individual, the question regarding the psychotropic drug or not for dementia and continuing to use it. So the other issues, so a facility requesting medications to address behaviors, because they're unable to address the behaviors with non-pharmacological interventions. Surveyors may suggest this is for convenience, and that's, you'll see that a lot, is that back to the first slide I showed, which was this article suggesting that the staff is asking for these drugs in order to knock these residents out and keep them in their beds. And I don't see that, at least, I haven't seen that in the clients that I work with. Certainly, they're asking for the medication because it's needed. And these residents have behavior issues. They have behavioral problems related to their diagnoses. And again, they can, if a surveyor comes in and starts looking at the use of the psychotropic medication for purposes of addressing behaviors, they might also look at chemical restraint. Obviously, that would be an issue as well. Another issue would be the ambulatory resident is prescribed an antipsychotic for delirium, and significant side effect is that the resident ends up staying in bed and they develop a pressure ulcer. That's actually one of the scenarios that they give in the regulations, that facility or a surveyor would look for is if you see that the resident is on a medication that's causing them to be not able to get out of bed, and then they have these other things that come up because of that. The severity level 1, that's so when you're looking at a deficiency, it's not available for this tag. So it would be, you know, the lower level deficiency, they say is not available, because if you have a deficiency at this tag, there is the potential for harm. And so they are automatically going to go to a D or above on citing these deficiencies. So that's of concern for facilities, certainly, because then you're starting to look at, you know, potential fines and penalties. I think there's another question in the box. So where does bipolar DO fit? It is an enduring condition, and psychotropic medications are FDA approved, but facilities start demanding reductions. Any suggestions? Again, I would defer to the physicians on the line if anybody has any comments to that. So where does bipolar fit? It is an enduring condition, and psychotropic medications are FDA approved, but facilities start demanding reductions. Any suggestions? And yes, so facilities are under immense pressure to reduce the use of antipsychotics, as you can tell, especially given that where we rank in the state. So you are probably going to get that. Is there, certainly the documentation is important for you to explain that, you know, this is a condition that requires the use of that drug. Is it possible to do a reduction of some amount to at least show an attempt? That would be the first comment that I would make. I would say, do others have thoughts on how that might be addressed? You know, I would go back to your facility and just, again, reiterate that the diagnosis supports the drug, that other, you know, evaluate what other interventions have been tried. If you can show that those did not work and were not successful, I think that supports your continuation of the drug. You know, you want to look at the interventions and the response to those interventions. And if you can show all the things that we've just gone over with regard to evaluating and monitoring and making sure that the drug is effective for the purpose, then I think to continue it makes sense. And again, it's very important for the documentation to be there. And I would, you know, it would be nice, honestly, if we could all have this conversation. It would be important for facilities to also be able to hear what you all have to say. And so I don't think I mentioned this before, but I do work with the Nursing Home Association and serve as their outside general counsel. And so maybe it would be a good thing for all of us to sit down at the same table and talk about the use of these drugs, because they look at it from their regulatory standpoint and say, we are under pressure to make these numbers go down, and you are looking at it from the resident needing the medication, and that a GDR doesn't make sense. And so, you know, certainly we want to all understand where each other are coming from on that. And so I'm not sure I answered the question adequately, but hopefully you guys can talk through these issues together, and we can all share some ideas, some best practices. Certainly would like to here's another question. Dr. Smith, the regulation required GDR, but the regulation does not say that the medication could not be returned to previous dosage if it is no longer therapeutic for the resident. Is that not correct? So it says the regulation requires GDR, but the regulation does not say that the medication could not return to the previous dosage if it is no longer therapeutic for the resident. So I think the question is basically, if you try GDR, it doesn't work, can you go back to the previous dose if it's you know, not at its therapeutic benefit? And I agree. I don't think there's anything that says that if you try the GDR, it's not effective, then you go back to what it was. I do think that that is an option, so long as you're showing that you've tried the GDR and you're evaluating whether or not, because again, the purpose of this, right, is to get to the optimal level, the optimal benefit for the resident. And so if you are documenting that that is the optimal level, that is the optimal benefit for the resident, then I think you can support that, and you can support providing the drug at that level. and I think that we all want to make sure that the outcome for the resident is the best it can be. And I think everybody is on the same page there, is that we all want what's best for the resident. And we certainly are trying to find the optimal and best use. So I think that I'm probably close to my time.
Couple more comments and questions in the chat box. So Dr. Harrison said, if 2 or more attempts have resulted in deterioration in condition for a previous diagnosis, then the GDR is contraindicated. This is what I use. Restating this on a basis. Any comments on that?
Dr. Harrison also added another one that says, for a patient who is indicated, stated, and attempted to commit suicide, how forceful can your intervention be? So in that instance, I would try to get the resident out of the facility, honestly. In my legal opinion, I'm not certainly not a physician, but I have seen we obviously can't use restraints, either physical or chemical. So we are that in my opinion, that resident doesn't belong in our facility. And I say that knowing that there are not a whole lot of options. Getting a resident out of the building is difficult. Finding a place to place that resident is difficult. So I say that knowing that there are certain hurdles that would have to be overcome. But for a resident who's committed or has stated and attempted, then I think that person definitely needs psychiatric evaluation and potential commitment. And I would certainly, that would be my recommendation. If a facility were to call me with that, I would say you need to transfer the resident. And again, in terms of intervention on the facility level, we're so hamstrung by the chemical and physical restraint. I mean, you wouldn't when I have lawsuits related to falls, for instance, and we're talking about, why didn't you do more? Why didn't you prevent her from falling? And they literally think that we can tie people down. And as crazy as that sounds, I mean, a psychiatric facility can certainly put you in restraint. A hospital can put you in restraint, but a nursing home cannot. And so we are in a unique and unfortunate situation given our very strict and burdensome guidelines and regulatory requirements.
Dr. Nevels had another comment as well, and Dr. Nevels is a psychiatrist, so he has a lot of experience with some of these things. He said bipolar disorder is a characteristic relapsing syndrome. Each relapse is normally worse than the last and tends to last longer and be more severe. But for some reason, it isn't considered enduring. It is also more common than schizophrenia.
Okay. So to the question, that was sort of to the question about continuing an antipsychotic for someone who's got bipolar disorder, and how do you continue to support that prescription? So I, certainly rely on your mental health team and refer those folks out to your mental health folks, and bringing in the multidisciplinary groups. That's also important. You want to have the availability of people with that background for your facilities.
Any more questions from anybody? All right. Well, we are going to take a lunch break now. We were going to have a membership meeting